And okay, we're recording. Let's see. So it's Tuesday, November 7th, and this is the first lecture of Unit 6, which is on psychotic spectrum disorders. We wanted to introduce up front the announcement that we sent out today about ProctorU, that we are needing to change our testing protocol. It's our responsibility to maintain exam integrity as best we can from a distance, and that's really hard to do. So we really do not intend to inconvenience anybody or add to anyone's stress levels, which we completely understand are very high, but it's our job to make sure the evaluations that we're administering are valid. So for our next exam, which is going to be November 20th, this is plenty of time to get set up. We have reduced the testing window to only be in the evening. We're offering times that should be compatible with people's work schedules, whether you work day shift, night shift. You have options either way. ProctorU can accommodate all of us. You can schedule exam appointments can be scheduled every 10 minutes, 5:10, 5:20, 5:30, 5:40. In that announcement, there's some links we have to go just log in for an account with ProctorU if you don't have one already, and a tutorial to just get you acclimated to it, make sure your computer can tolerate their software. And there's a live chat option when you get into ProctorU. So if you're having any issues scheduling, just live chat them. That's what our liaison told me today to recommend to y'all. So they can accommodate all of us at the exact same time if you all want to schedule it at the exact same time. That is not an issue. So within that window, give yourself 40, 45 minutes. That'll be convenient for you, and they will accommodate you. Don't worry at all.
Simone.
Hey, is this Adam?
No, this is Suzette. This is Dr. Fogger.
Oh, you really do have a froggy voice.
I do. What I wanted to say was to remind people not to plan on entering the exam after 7:30, because the exam is going to shut down on you, and the ProctorU people can't help you. So allow yourself plenty of time to get situated with the ProctorU people. I would give yourself at least 15 minutes before you plan on starting the exam. They will ask you for identification, usually photo identification, so anticipate that and have your driver's license or another form of ID available. It is recommended that you plug your computer in so that you've got a live wire connection as opposed to doing
Wi-Fi
at a distance. Thank you.
Mm-hmm.
Because you have a much better connection and it should be at a faster speed for you. They will ask you to remain in the frame. So if you're likely to slot over, they're going to ask you to sit up and keep your face in a certain position. Mostly what they're trying to do is to ensure that people are not adding extra variables into the exam. Your computer will need to have the camera ability, and it'll need to be turned on so they can see you. So that's my tutorial on ProctorU.
But in advance tutorial, and again, we've used this a bunch in our program. We used it with the class last year. The vast majority of the time, it goes without a problem. Just please, this weekend, it's plenty of time before the exam runs. Just go through the tutorial, go through the orientation to it. Pick a time that's convenient. So if you pick the 7:50 spot, now the exam is going to lock out at The exam's going to lock out at 9 p.m., a little earlier than the 10 p.m. lockout that we used to have. I would say that if you signed up, they will let you sign up until 8 p.m. So 7:50 is cutting it pretty close. But like Dr. Fogler's saying, if it takes you 10, 15 minutes to get, for them to verify you, and they'll want to see your space around your computer, those kinds of things. I think 7:50 you'll be okay. The exam's going to run about 40 minutes. The exam's going to run about 40 minutes as usual. That's how long it typically runs. But you want to account for maybe a 10 or 15 minute login period. And again, we regret that this is an added stress for y'all, and we regret that this is not as convenient as the big testing window. It's unfortunately our responsibility to make sure the exam results are valid, and this is just something that we're going to have to do. And Jennifer's mentioning crazy work schedules. The exam runs until 9 p.m. So with the purpose being to accommodate people who maybe work until 7, takes them 30, 45 minutes to get home. But this is unfortunately something that we are having to implement. And feel free to email us with questions or any problems that you have accessing ProctorU. We want to make this as painless as humanly possible. And yeah, Martha's asking a question about the exam. We went through that already. But Martha, if you and anyone else who wants to go over their exam again, by all means email us and we'll go over those items again. Yep, this is the ProctorU issue is not meant to be a stressor. We will make it work. All right. So yeah, email us with questions. We'll get to your exams, no problem. So let's go ahead and get started with the new information. I don't think tonight's class is going to take particularly long. I can hope. You never know when I get started. So psychotic spectrum disorders. Schizophrenia is a chronic and potentially acute and very dangerous to self and dangerous to other. Yeah, Martha, please do messages. It's one of the main reasons why people end up in inpatient care, because they lose the capacity to maintain their own safety. They lose reality testing. And this is something that will not correct itself on its own. I'm sure a lot of y'all who've worked inpatient community mental health have worked a lot with folks with schizophrenia. We'll talk about the changes from DSM-4 to 5. So here's the issue. Schizophrenia.
What?
Criterion A, it's 2 or more of the following.
I'll do it after this lecture.
Of those symptoms, there are delusions, hallucinations, such and such. Which of those do y'all, just in your own opinion, are the most concerning symptoms that someone would present with? Yeah, delusions and hallucinations, yeah, those delusions and hallucinations tend to upset other people the most. I completely agree with y'all. Yeah, and those are the positive symptoms, which I think we're going to talk about in just a moment. Yeah, we will. This is impaired reality testing. This is believing things are true that are not. This is hearing things, interpreting. It's not even misinterpreting a sensory input, because that would be more of a illusion that there is actually a stimulus initiating that interpretation. This sounds voices most of the time that are not there, that are not being generated from the outside. And we talked about that CSTC loop last week or week before, that it is a misfiring, a generation of an impulse. In this case, it's a thought that is not actually there. So those positive symptoms tend to get other people very concerned. And they're positive in that it is more than should be. It is beliefs that shouldn't be there. It's hearing and seeing that shouldn't be there. And then you have disorganized speech, disorganized behavior is also considered, I believe, a positive symptom, if I am correct. It's not listed on the next page, but disorganized speech, disorganized behavior. Also, when you're talking about CSTC loop and the striatum's job in filtering out impulses and motor programs that this is my objective, so this is what I need to do to meet my objective. That's really what disorganized behavior is. It is behavior that does not have an apparent purpose. It's not linear, logical, or goal-directed. It is disorganized. Like wearing Mardi Gras beads and, putting, the example I like to use is filling Tupperware containers with olive oil and putting them on your porch and tearing up Bible pages and crumpling them up to put around your bed for a protective barrier against, no, it is behavior that is not directly connected to an outcome that is logical. Negative symptoms. Negative symptoms don't upset other people as much. This is like positive is too much of something that should be there. Negative is not enough of things that should be there when we talk about affect and initiating behavior, even if it's seeking food, even if it's getting up to walk to the bathroom. It's a lack of initiation, of speech, of affect. It's really, it's an absence of a lot of things, like a failure to initiate. A failure to initiate. Affect will be flat. Speech will be impoverished. No spontaneous speech. One-word answers, if any, in response to questions. So 2 or more of those symptoms, and very often delusions, hallucinations, and disorganized behavior will co-occur. Negative symptoms can exist on its own, and may exist on its own, and also is harder to treat and tends to be residual. If you think about folks with schizophrenia with whom you've worked, they will be stable on a medication, meaning they're not floridly psychotic, they're not responding to internal stimuli, they're not aggressive, they're not labile, they're not anxious, they're just sort of a shell of a person that's left. Those negative symptoms remain. Like all disorders, results in impairment. You have to have, again, prominent, those two of those prominently evident for a month, but some sort of, maybe just one of them, maybe just one of those symptoms have to be present for 6 months to be considered schizophrenia. So pretty intense, multiple symptoms for a solid month with some evidence of continuous disturbance for 6 months. Like anything else, you have to rule out. You rule out substance, you rule out something else, you rule out thyroid, you rule out anything else you can think of. Like all of our other disorders here. And you can Google the 4 A's of schizophrenia if you want to, because that's how it used to be conceptualized. The 4 A's of schizophrenia, one of which was autism. And autism it comes from auto, self. It is a self-focus and a lack of engagement with the outside world. And you'll see that as a negative symptom in schizophrenia. So This last criterion, F, says that if the person also is diagnosed with a pervasive developmental disorder, autism spectrum disorder, you can also be diagnosed with schizophrenia, but it has to be prominent positive symptoms because of the overlap between the negative symptoms of schizophrenia and autism. Now, of course, someone would be diagnosed with autism probably by the age of 3 or 4. You're not going to get diagnosed with schizophrenia at 3 or 4, kind of like you won't get diagnosed with autism at age 20. So they're just saying that one does not preclude the other. You would just need positive symptoms on top of the developmental disorder. We talked about those positive symptoms. Delusions, it's a fixed false belief. Go back. It's a fixed false belief that you can't convince them otherwise. Hallucinations, they're most often going to be auditory. That's the most common type of hallucination. There can be visual hallucinations, certainly, olfactory, tactile, but really visual hallucinations, while they may exist in schizophrenia, are often related to some sort of medical cause, like certain types of dementia. Parkinson's dementia and Lewy body dementia can have visual hallucinations, substance use, current or historical intense substance use, visual hallucinations. So if people come in, you just want to be suspicious if someone presents only with visual hallucinations and they're otherwise very organized and very well kept. That's not how schizophrenia works. Like Dr. Fogger was mentioning, there's often a prodromal phase to schizophrenia where negative symptoms and a reduction in functioning precedes the onset of the acute positive symptoms. So for someone to just, over the course of 3 or 4 days suddenly are reporting really intense hallucinations in the absence of disorganization, in the absence of any delusions, you might think, kind of suspicious of that. Then you have the negative symptoms: poverty of speech, poverty of interest, affective flattening, not a lot of facial expression, not a range of affect. You may have somewhere between flat and constricted. There may just be no emotion evident. Minimal activity. I remember working intensive outpatient in Mobile, and the folks who had real prominent, you might call it residual schizophrenia, what you used to call it, when they have extended periods of no positive symptoms but lingering negative symptoms. These folks, they would sit and would have to be prompted to stand up, to get in line, to go to lunch, or would have to be prompted to stand up, to leave the classroom, to go outside. There was spontaneous initiation of activity. Does that remind you of any other disorders? Difficulty with initiation of action? Parkinson's, exactly, which is also a dopamine striatum deficit. That's exactly right. So there's only so many neurotransmitters in your brain. There's only so many structures. So there is going to be overlap between syndromes when the mechanism causing it is maybe present in both. But yes, that's exactly right. In addition, there's other cognitive symptoms of schizophrenia that are very difficult to treat. Problems with attention and abstraction and more complex, completing more complex tasks, multiple steps in a row, focusing. Speech is abstract, speech is symbolic, so that will be impaired. And I'm sure it's very scary. I can't imagine having schizophrenia. I would think it's tremendously frightening. So in younger men in particular, especially if there's a lot of positive symptoms, if there's delusions of persecution, there may be anxiety. Anxiety may take an active form with aggressive behavior, especially if substance use is involved. But people with schizophrenia are not in and of themselves violent, not at all. People who are really scared and can't make sense of their environment can be aggressive or violent, but I think schizophrenia gets some kind of feedback. I'm sorry. I'm still hearing it. Huh. Yeah, sorry, y'all. Just trying to knock that feedback out. So we're going to talk about Jim real quick. Jim's a 19-year-old male brought in for intake by his dad. His grades at UA Huntsville started to decline. He's 19. A couple months ago, he quit going to class. He'd sit in the back of the room, seemed to be kind of, you could see his mouth moving like he was making comments to himself, but no one else. He would smile when that was not contextually an appropriate response. Friends said he's essentially acting bizarre. Self-care has declined. He's rearranged furniture in his room. He's thrown things out. And his sleep is way off. With schizophrenia, as illness approaches, sleep is going to go away, and kind of subclinical bizarre behavior may take place. Things that are just not typical of that person. They will withdraw, especially from things that are linear, logical, or goal-directed, like going to school. It's a long-term goal. You're doing this to achieve a degree in 4 years. That forward-thinking, kind of prefrontal cortex, this makes sense, I'm going to do it, this is a long-term consequence I want to avoid, because that part of the brain is no longer running the show, unfortunately. So mental status is very important in the assessment for schizophrenia, as you all know, because affect, rate of speech, initiation of speech, content of speech will not be typical. It will not be within normal limits. Because when you think about it, showering and combing your hair and changing your clothes and switching into your winter wardrobe as opposed to your summer wardrobe, all of those things are designed to communicate socially. That is a very high order activity that is meant to communicate to other people your interests, your degree of self-care. You want to be appropriate to the context. You want to be appropriate to the setting. Those are also pretty complex. There's a lot of steps involved. With self-care, we do it pretty quickly and we do it without thinking, but that's a sequential multi-step process. And those are the parts of the brain that are no longer influencing activity when someone is becoming symptomatic with schizophrenia. Clean, fitting clothing, the season, those are all social constructs, and that's symbolic, and that is not considered for someone with schizophrenia. As may be personal space and mannerisms and how you sit in a chair. It does not influence their behavior. It does not inform the behavior. And then his speech is loose, to say the least. So diagnostic impression, I don't think there was any delusions necessarily apparent. Yeah, there's no delusions necessarily apparent in there, but as far as his clothing and his presentation, you could say that that's disorganized if the person has on, 3 shirts and lots of bracelets and 2 hats, and that would not be organized according to societal standards. So he exhibits the hallucinations. He seems to be hearing someone and speaking to that person, and his speech and behavior are certainly disorganized, in addition to negative symptoms of the withdrawal and things like that, and his affect being constricted. Schizophrenia is rare. It is genetically loaded, so it can run in families. I remember when I was at Alta Point in Mobile, UAB researchers were coming down to they were doing a study for folks with schizophrenia and first-degree relatives, probanes who also had the disorder. So really, if you know of a family history of someone diagnosed with schizophrenia, and the family may say, well, so-and-so had to go, they lived in the state hospital for a long, long time, or they went to the hospital and then they went to a group home. Those are, even if the family doesn't know the diagnosis, those are cues that the person was more than likely diagnosed with schizophrenia if they were functioning fairly well and then had to repeated hospitalizations and now they're living in a group home. It may inform your diagnostic approach to maybe an 18 or 19, someone like Jim. It may lead you to consider schizophrenia more strongly than, well, maybe he seems depressed. He's not going to class. He's not showering. He's just withdrawing from his life. With a family history of schizophrenia, you want to certainly consider that. Men are diagnosed roughly equally to women, maybe slightly more. The main difference is age of onset. Schizophrenia, typical age of onset for men is younger than for women. So for the women in the class who've made it to their mid-30s without schizophrenia, the good news is that you are unlikely to present with this disorder. Whereas men, the onset may be earlier. And it even seems as though for African American males, the age of onset is younger compared to Asian American, Latino males, Caucasian males. So that's just kind of an interesting tidbit that it tends to present. All the psych meds too, lots of related. Yeah, okay, I see what Sabine is talking about. Seems a deficit in executive functioning. Yeah, Kelly, with planning, with consequence, with that's certainly going to relate to. Yeah, and I don't mean to communicate that suddenly they're not aware of societal norms, and that's why people with schizophrenia suddenly don't care about how they dress and those sorts of things. But what I mean to say is when you're looking at Maslow's hierarchy, self-actualization, who you want to be, your personality, your interests, your goals, your self expression, that's real high order stuff. And as an organism becomes sick, be it from a psychiatric or a medical illness, you pull energy away from those pursuits and it becomes much more basic. And that's what's happening here. So the executive dysfunction is the driver behind what presents, like the executive dysfunction is in the brain. The observable outcome is the social inappropriateness and the disorganized behavior and the disorganized speech. the withdrawal from things, the, not paying bills anymore, not locking your door when you go home. So the executive dysfunction is the mechanism that results in the disorganized behavior. One of the dysfunctions that results in that. So no, it's not that suddenly they don't, not to say that the social part of their brain's off. No, that's just what it looks like out in the world. If it's not linear, logical, goal-directed, then it's disorganized. So there's a failure in the linear, logical, goal-directed part of the brain. From a psychotic point of view, positive symptoms are easier to treat than negative symptoms. So positive symptoms, you have a better prognosis. If it was a pretty quick onset, you have a better prognosis than a real gradual, long prodromal phase with lots of negative symptoms. Those folks tend to stay sicker for longer and never quite recover to pre-morbid functioning. If this starts young, if there was already an anxiety disorder, if there was a trauma history, if there's limited education, limited social support, limited access to good care, those indicate a poor prognosis. So negative symptoms, not a good sign. Extended prodromal phase, not a good sign. Those tend to be the markers for a more severe illness. I think we talked about the prodromal phase, the withdrawal, lack of any kind of affect or enjoyment, just doing sort of odd things, not concerningly odd, but odd. For every period of illness, folks do not return to the same level of cognitive functioning after periods of illness, and they lose IQ points when tested. And like Sabina was saying, the medications that are required tend to have a lot of metabolic side effects and therefore cardiac side effects. The kind of food that you're able to eat. Just think, if you have schizophrenia, there's a good chance that it will be very difficult for you to, unless you manage it really intently and you have a lot of support, it can be difficult to have a fantastic job with fantastic insurance that gets you regular medical checkups and gets you access to foods that prolong life instead of shorten it. So you can see how schizophrenia, people don't live as long with schizophrenia because of medical and medicinal and nutritional problems that go along with this disorder. Have you seen? Kelly's asking if client presents predominantly positive symptoms the first couple episodes, have they later developed negative symptoms? Kelly, I don't have a good percentage to give you for that. I have certainly worked with people who, when they're sick, it's positive symptoms, and when they're well, there are no negative symptoms, kind of filling in the gaps. But a lot of people will present with a combination of both. Sometimes seems like more than one illness. You mean schizophrenia as a entity seems like more than one illness, or? Yeah, it's the same theoretical dysfunction that causes the positive and the negative symptoms, and we're thinking at this point that it's actually a glutamate. It used to be dopamine. Well, now they have discovered there may be an earlier step in that process, something that causes the dopamine dysfunction. Why is there too much dopamine in the mesolimbic tract to cause this emotional, lability and this positive symptoms, and why is there not enough dopamine to promote cognition and emotional processing? Because it's not just an issue of there's too much dopamine, there's actually not enough dopamine active in the prefrontal cortex, in that tract, from where the dopamine starts to where it ends up in the front of the brain. So really, there's always going to be the possibility that someone developed both. And really, the people with whom I've worked, I would say a third of them are predominantly negative symptoms, and I don't know, I'd say a third of them are almost exclusively positive, and then a third of them are both. And the other thing, too, is positive symptoms can be so disruptive that it's not until you treat them and they go away that you can see, oh, now there's a deficit in activity and interest and affect. Is it difficult to differentiate MDD with psychotic features and schizophrenia with predominantly negative symptoms? Not really, I wouldn't say, and it's all about the timeline. That's a really good question, though, Hannah, because with depression with psychotic features, the psychotic features are typically delusions, a lot of times it's delusions of guilt, but it's not, you may have auditory hallucinations, especially if they're persecutory and negative and critical and horrible. But with MDD with psychotic features, you would only have those psychotic features in the context of MDD. And there would have been, fluctuating moods. There would have been euthymia at some point. With schizophrenia with negative symptoms, that is, the negative symptoms are not, they're not, what's the word I'm looking for? Episodic. The negative symptoms are there. The person develops schizophrenia, the negative symptoms become their normal, and they don't change. They don't go away. And when you look at the other factors of MDD, sadness is not a symptom of schizophrenia. Suicidal ideation is not a symptom of schizophrenia. Appetite changes are not a symptom of schizophrenia. So if you look at the distinguishing features between MDD, sure, people who are depressed have trouble thinking and they don't really want to do much and their energy is low, but they're still capable of emotion. It's probably going to be sad or irritable. And the psychotic features are going to be positive symptoms, and they're only going to be present in the context of a mood episode. So I don't know if that answered your question, but really that is why you want to really memorize, schizophrenia doesn't in and of itself carry a mood component or a depressive component. We're about to talk about schizoaffective disorder, which is a whole different thing. So that's probably going to be the harder one to distinguish, is MDD with psychotic features and then schizoaffective disorder. But that is a really good question, and I'm glad that you're thinking about that. Metabolic syndrome. MS. Oh, metabolic syndrome. Adam's saying MS is the #1 cause of mortality for those using second-generation antipsychotics. Yeah, heart disease, cardiovascular disease seems to kill everybody these days. So anything that's going to worsen your cholesterol and blood sugar, and it's, your triglycerides try to go up because you're trying to package all the sugar you don't know what else to do with. And really, I guess the main thing is if you've worked with a lot of people who are depressed and you've worked with a lot of people with negative presentation of schizophrenia, they present differently. I don't want to say that it feels different sitting with them, but it does. So this is just going to be something that memorization of the clinical differences and just experience over and over and over again. Age of onset, course of onset. So schizophreniform disorder is just schizophrenia that hasn't been present for 6 months yet. That's all that is. Brief psychotic disorder is briefer, right? Usually following some stressor. It's kind of like schizophrenia, but in response to a stressor, and it completely resolves in a month. I personally have, maybe I have worked with one person who met criteria for that. Not a lot of people. And again, from a time frame standpoint, that's really the distinction there. But the DSM wants to communicate that these disorders are on a spectrum that are similar but maybe present for different amounts of time. Schizophrenia, this is a lifelong illness that will require treatment lifelong for the person to maintain, to achieve recovery and then be highly functional. There's no reason that folks with schizophrenia can't lead meaningful lives and work and have relationships and engage in personally relevant activities. There's no reason they can't do that with treatment. Delusional disorder. This is different from schizophrenia in that there's no hallucinations, and if they are, they're brief and they're not clinically significant. But this is someone with a fixed false belief for at least a month. And there's different types. Whenever you hear about stalkers who, I think Jodie Foster had a stalker. I don't know why I'm remembering her. Maybe somebody tried to jump the fence and get in her house or something really scary like that. But that is an erotomanic delusion. It's when you are convinced that someone else is in love with you and you need to be with them. You need to be together. And we're supposed to be together. And I know we're not together, and I know we've never met, but trust me, we are soulmates. And there's no convincing them otherwise. Grandiose, they are special. They have, they're going to invent some special, amazing, life-changing product. They have some fantastic idea. These people with delusional disorder, they don't present as odd. There's no negative symptoms. There's no bizarre, disorganized kind of behavior. There's just a singular fixed false belief. Persecutory, that someone is, people are out to get them. They're being poisoned, so they just don't go to this particular mall because they're convinced that the people who own that mall they're poisoning people, and I'm just not gonna go. They're otherwise functioning. There's no hallucinations, really. There's no negative symptoms disorganized. The jealous delusion, that is specific, the belief that your romantic partner is unfaithful, even though there has never been any evidence to that. You can imagine the strain that would put on relationships. Delusional disorders are very difficult to treat as well. Even with antipsychotics, they tend to persist. But the good news is the folks they're not tremendously impaired. They're maintaining self-care. They can maintain work. They're organized. They're logical. They just have, I'm trying to think of some famous person. Aaron Judge, the baseball player, is is your soulmate. And when you see him on TV and he hits a home run, he did that for you. He did that just for you. And you were going to go and meet him and you were going to prove there's no evidence for any of this. But delusions don't need evidence. Schizoaffective disorder. This is a challenging disorder. It's not as common as schizophrenia, thankfully. But you have an uninterrupted period of illness where criterion A of schizophrenia is met. So delusions and hallucinations, or which is probably what it's going to be, some sort of auditory hallucinations and some kind of delusion of persecution. Long time, long period of illness. And at some point during that time, they also meet criteria for a major depressive episode. Maybe they quit sleeping and they're really irritable for 2 weeks. We're talking about not just a day or two. They meet criteria for a major depressive episode. They don't want to eat. They don't want to get out of bed. Can't sleep. Real irritable. Thinking of hurting themselves. The symptoms of psychosis never go away. You're just superimposing on that a mood episode. Or the person, their voices get worse. That might be the cue that they're about to have a mood episode. They get real irritable. They quit sleeping. They're distractible. They talk fast. They argue a lot. They're busy outside. Maybe they have a manic episode in the midst of the auditory hallucinations and the delusions of persecution by the neighbors. But the mood episode will resolve, but the symptoms of psychosis do not. So from a time frame standpoint, the psychotic symptoms are there. They're long-standing. You superimpose a mood episode. The mood episode may resolve the positive symptoms. The hallucinations, the delusional content remains. And that will fluctuate and come and go. But the psychotic symptoms never fully resolve in the absence of a lot of treatment. It is good, I suppose, that you can treat bipolar disorder with the same medications that you would use to treat a psychotic disorder. If it's depressed type, then you could add antidepressants to the antipsychotic medication. But these are folks that the psychotic symptoms are the baseline and the mood is superimposed on top of it. With depression with psychotic features, the mood illness is there. The mood episode is there, and you superimpose delusional thinking or auditory hallucinations on top of that. So the order is reversed, essentially. And it's just real challenging when you're working with folks that they have both and you don't know which one came first. That's why timelines are so important, and that's why other informants are really important. Childhood onset schizophrenia, again, it's rare, but it happens. Kind of mid-adolescence. So you're looking at this, 80+% of people with schizophrenia will have their first episode 18 and later. But you have some who are especially going to have that prodromal phase, an extended prodromal phase in high school, you would say, in early to mid high school. So when you're working with a 15, 16-year-old boy in particular, remember onset for men is younger than women. If there's a family history of this stuff, you really want to consider it. Of course, you would distinguish this from autism spectrum because autism does not present at 16. It is going to be present from the outset. So this is mainly an issue of, because you can see how this might look like depression presenting in a 16, 15-year-old boy. They're not sleeping. They don't want to do anything. They don't care about anything. I don't want to go to school. I mean, this looks a lot like depression here. But depression does not go along with bizarre behavior, different rituals, talking about things they didn't used to talk about, disorganized thinking, disorganized behavior. That's not depression. So if there's a family history of schizophrenia, you would more so consider that. And you also may have an instance where you try to treat it with an antidepressant and absolutely nothing happens. But again, this is rare. There's a family history, you would consider this. But the odds that it is depression, well, actually the odds that it's substance is best. And then mood, something situational, and then schizophrenia. So you want to think horses and not zebras, but UAB Hospital runs a first episode clinic trying to treat young people who are having their first episode of psychosis, which is eventually going to end up in schizophrenia, to try to more aggressively treat the illness, higher doses of medicines earlier on to try to correct the imbalance and prevent just this overly excitable state in the brain that's very toxic and causes the damage. Treatment priority, obviously. Are they suicidal? Are they violent? Are they going to get themselves into trouble with other people? Are they going to evoke aggressive responses from others because of the patient's presentation? They're at high risk for being a victim themselves of violence from others. And if they can't take care of themselves, then they need to be in the hospital to have their executive functioning corrected if possible, to support them in maintaining self-care and safety until they can be in touch with reality again. Because someone who is psychotic, you want to be you want to be direct. You don't want to be aggressive. You want to explain things, what's going to happen. You don't want to be vague. You don't want to be subtle, because they're having a hard time interpreting what's going on, and they're probably going to be scared, and people, when they're scared, will protect themselves. And really, you need to reduce the disorganized thinking and the delusions so that an interview is possible. These are people that you may need to treat for a while until you can have much more of an interview. Once the person's stable, the idea is relapse prevention, and that's going to be medication adherence. That's going to be stress reduction, because stress will increase the likelihood of a psychotic episode and initiating another period of illness. We know that when cortisol goes up, it changes how cells, the equilibrium within your whole body, including how cells function. So the first episode of schizophrenia often is following a significant stressor. And one of the most stressful things that tends to trigger episodes of psychosis is conflict within the family, emotionally volatile family environments. So this is going to require educating parents, siblings, partners, wherever the person lives, that social stress and conflict is going to increase the chance that they get sick again. We talked about this a little bit. We're not going to talk about it much tonight because this is next week's focus. Not the symptoms, but the underlying mechanisms. Some really good readings in Stahl and in Psychotic. I would say focus on those two readings, Stahl and Psychotic, for the dopamine tracks. The main ones that we're concerned about is mesolimbic, because that's the volatile, emotional, delusional, positive symptoms seem to be driven by that. And the negative symptoms seem to be driven by disruption of the mesocortical tract, like the cortex. And meso just means middle. They're talking about the midbrain, where the dopamine neurons originate from. The ventral tegmental area, the VTA, meso, middle. That's what they mean. And then it projects to the limbic system, the nucleus accumbens, the striatum, which is right next to it, and mesocortical, the dorsolateral prefrontal cortex, and then the ventromedial prefrontal cortex. One is more cognitive processing, one is more emotional processing, and that's what seems to be deficient when you're talking about negative symptoms of schizophrenia. And we'll talk about managing side effects more so. And the side effects really have akathisia and EPS have to do with imbalance of acetylcholine and dopamine in the striatum, as far as maintaining calm at rest and having deliberate movement. This little slide, y'all didn't have it, but it just kind of summarizes. We're going to talk about this more next week, but we just wanted to introduce it. I really do recommend reading Stahl's chapter on antipsychotic medications, because it's going to explain why some of these meds are more sedating and why some of them are not, why you tend to increase and decrease the pins slower than you do the DOMs, because really your pins are going to have more activity at histamine and acetylcholine receptors. So, and they tend to be more sedating. They tend to be more anxiety provoking if you decrease them too quickly, as opposed to Geodon and Vega-Risperdal. They may not be as sedating. They may not have as many anticholinergic side effects, as many sedating antihistaminic side effects. They're all atypical antipsychotics, so they all block D2 receptors. They all block serotonin 2A receptors. That's what makes them atypical. That's what makes them less likely to cause the extrapyramidal side effects. They're less likely to cause tardive dyskinesia, but they certainly can. You have orals, you have injectables, and this is just a list of some of the newer, well, Consta's real old. But from a treatment standpoint, if someone has a hard time being consistent, and especially with schizophrenia, some folks are just really prone to episodes of illness. They become sick really easily. They can miss just a few doses of their oral antipsychotic, and the next thing you know, they're not sleeping real well. They're talking about strange things. They're not going to their appointments anymore. They're walking around the streets. They're not, and you can just tell when they're getting sick. So having 2 to 4 to 12 weeks of medicine on board can be helpful. These are new. Invega Trenza's newer. I personally don't know anyone who takes that. I think it's available at UAB. I'm not the best person to ask. But Consta, Q2 weeks, and those are also the indications. If you notice, in Vegas, Sustenna is the only one indicated for schizoaffective disorder. All of them are indicated for schizophrenia, some for bipolar disorder as well, but you have options how often the medication needs to be administered. The person can come in every 2 weeks. With Trenza, you only need to take it every 3 months. That's pretty amazing. But with those long-acting injectables, while it's helpful for stability because there's a steadier blood level, you don't have to take a pill every day, very often folks will have to also take some kind of oral antipsychotic to boost it as well. And with all of these, the manufacturer says, this is how you do it, this is what you do to start it. But you want to assess tolerance of the medication in an oral form before you would order the injectable. So you might say, okay, sir, I think that Sustenna is going to be the way to go for you. You don't have to, you won't have to take as much PO medicine, but what you would do is you would give a PO form for 3 weeks, 4 weeks, assess tolerance before you dump a month's worth of medicine in this person. So you would do an oral challenge is what they call it, and then you initiate the medication. And while it's getting to a steady state, you would continue the oral formulation for maybe 3 or 4 weeks, and then you stop it, at which point their blood level from the injectable, the suspension, has been achieved. So if you're working in a setting, and a lot of y'all I'm sure know this already from where you work, but if you're initiating this and you're wondering, well, why are they having to take it orally for a month before we give the injectable, or why are we continuing the oral after they're on the injectable? It has to do with making sure they're not allergic to it, and then maintaining the PO while the steady state is achieved. And then you would gradually remove the PO and assess are symptoms increasing at all, and find the point at which, all right, all you need is, we'll keep you on 1 milligram of risperidol at night on top of your Sustenna. Because not everybody's going to have remission on just the injectable. So they may need both, even long term. DSM-5, we used to have schizophrenia paranoid type, disorganized type. There's no more schizophrenia subtypes, it's schizophrenia. And then you list out the symptoms. It would be hallucinations, delusions, avolition, same in schizoaffective disorder. Nothing tremendously important on this slide, but just know some people might not. Charts may not say paranoid versus disorganized. A lot of charts probably still will. But DSM-5, there's no more subtypes. Delusional disorder, the delusions used to have to be non-bizarre, but in the absence of other significant positive symptoms, the delusion can be that there is some sort of alien, I don't know, I usually have a hard time making up delusions sometimes when they're bizarre. But you can see my partner's cheating on me. People are trying to poison me. There's poison in my yard from the yard man, something like that. That could technically happen. A non-bizarre delusion could technically happen. The government has bugged your cell phone, so you have to change it every 2 months. That could technically happen, but you're getting messages from an alien race, and that's why you have to change your cell phone every 2 months. That is bizarre. That's not going to happen. You can see the distinction between bizarre versus non-bizarre. But if that's the only symptom, it's still delusional disorder. Next week, lots of conversation about the dopaminergic tracks, med management, why the side effects happen, glutamate, dopamine, acetylcholine. more about the drugs. Drugs. That's what we're going to talk about next time. So that is it, ladies and gentlemen. And it's 8:05. So any last minute questions before we shut it down? Uh-oh. And again, please do email us with any kind of questions. Don't hesitate to do that. Any Proctor U issues, exam questions, those kinds of things, just let us know, okay? And that is it. Quick guide from APA. Oh, I think you're referring, Deborah, to that schizophrenia treatment guideline. Yeah, don't read that. Please don't read that. That is available to you. It's also getting on the older side of things. So,
Simone?
Yeah.
Because it was so old, I went online to look for APA's updated one, and they haven't updated it, but I added a Canadian one that looks at community treatment, which is a different angle, but it will supplement the older APA guideline. And it talks more about community treatment and assertive community treatment, particularly ACT groups.
Yeah, acting and stuff.
Yes.
Yeah, no, I'm glad you mentioned that. But yes, Deborah, that is there to let you know really big guidelines exist. You don't need to read that stuff. You do need to stay with what's the word, digestible and current. But we're going to talk about a lot of that next week. All right, everybody, we will shut it down and look forward to hearing from y'all. See you next week.